this thing. First, we will share the screen and do this. So there are almost 45 people on the board, and let me welcome everyone and welcome to this evening PGNAR session, which we call earlier we used to call it PGNAR, but now we call it as a digital seminar organized by Dermatologists Consortium of India, and everybody is a member of that. And the consortium means we all are anybody is member of that. So this time it is a resistant fungal infection, and resistant fungal infection. We have got speaker none other than Professor Dr. D.G. Saple in that. So Dr. Saple, please accept a virtual bouquet from our side, Rajasthan Hospitality and Jaipur Hospitality especially, and have a turban of this thing. And I'll request Dr. U.S. Agarwal, who is a very senior dermatologist over here, ex-principal of SMS Medical College, to formally introduce Dr. Saple.
Good evening, everybody. It is my privilege to introduce Professor Dr. D.G. Saple, the Fellow of the Johns Hopkins University, Bloomberg, United States of America. He is retired honorary professor and head dermatology, beryllin and leprosy, Grants Medical College, and Sir J.J. Group of the Hospitals, Mumbai. He is a pioneer researcher, clinician in HIV and AIDS in India, and the first to use fluconazole 150 milligram daily dosing in India. At present, he is consultant dermatologist, venereologist, nephrologist, and HIV/AIDS specialist at Breach Candy Hospital and SL Raheja Hospital and Fortis Associate, Mumbai. He is a trainer of the fellowship program in HIV/AIDS, IDBL, ex-president, IDBL Maharashtra branch, ex-president, College of Physicians and Surgeons, CPS, Mumbai, examiner for MD in various universities. He has delivered more than 1001 lectures across country and represented country in over 108 international conferences. Sir, it is not, yes, please. Ex-editorial board member of IDBL Textbook of Dermatology, IGSTD and IJD, 40 plus peer-reviewed publications, chapters in medical textbooks, 55 plus papers presented at international conferences. He has organized many conferences, including National Conference of the STD and AIDS 5 times, and he is the international collaborator in academic research with Harvard School of Public Health, Johns Hopkins University, University of Yale, University of Tomiya and Osaka, University of Jobaku Nettle, and University of the Roma, amongst many others. He has got many awards to his credit, including Lifetime Achievement Award conferred by IMA in 2017 Mumbai, Lifetime Achievement Award conferred by IDBL in 2018, Best Practitioner Award in Dermacon International Congress 2019. He has been honored as a member of the IDBL Fellowship Dermacon 2020, and his current research project is dermatophytosis clinical research, and we are privileged that today he will be enlightening us on resistant dermatophyte infections. Welcome, Dr. Sapne.
सम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय. I'll request Dr. Lalit to kindly present a felicitation, virtual felicitation to Dr. Saple.
Welcome, Professor Saple. It's indeed our honor to host you today to this very contemporary talk on dermatophytosis, recalcitrant dermatophytosis. And we request you to kindly accept our token of appreciation, a memento and the scroll. Kindly accept these. So now the screen is all yours, sir.
Okay, thank you, thank you. I'll take few seconds. Yeah.
So almost more than 75 people have joined, and please start your presentation. Make it on the full.
Yeah. First, let me thank Dinesh, Dr. Agarwal, Lalit, and their team. It's a nice organization. What you are doing is a great work, because during COVID time, I heard Mahabharat. And Mahabharat, they have mentioned in Mahabharat, the greatest things in life is to share your knowledge, keep on teaching people. And Dinesh, you and your team is doing really what is mentioned in Mahabharat, the greatest donation in our life. Anyone to donate something, they should donate their knowledge to colleagues, friends, and everybody. So that is a very great work you are doing. Thank you very much for giving me this opportunity to share my experience about resistant fungal infection. So when I'm talking about resistant fungal infection, all of us, we know that this has become an ordeal, not only to the patient, but even dermatologists, because we were perplexed. We were not knowing how to manage it, and whatever the guideline is given by the Western books, literature, that was not enough to treat. But this is happening over the years. So talking about this, so I thought I'll first show how I was perplexed. When this patient came to my clinic, I thought this is tinea, and this also multiple erosion and superficial ulceration. I thought probably I'm dealing with HSV, genital herpes. That's what I thought, because that is the common present genital herpes with the multiple eruption with the discomfort. But as I'm involved in the, now HIV has come under control. Of course, still my main practice in my private clinic is HIV, but clinical dermatology also part of it. And then we did a scraping from here. And for all of us surprised, we found there were mycelia. We were really surprised, because we never heard about dermatophytes or tinea affecting mucous membrane. Then we treated this patient with itraconazole, and everything disappeared. Say everything disappeared. So then I started looking for the literature, and there are articles that tinea involves perianal lesions, involved in the mucous membrane, the glands, and involving even these labia majora, minora, or even the internal. So there are few articles about involvement of involvement of the mucous membrane in dermatophytes, but there are very few. So I thought this is how we have to look for it. And yeah, so in this lecture, I'm mainly going to talk about the uh, I'm going to talk about the resistance, but I thought we should have some idea about this. So there are many things we got to covered. What is the changing scenario? What are the problems of dermatologists? How we are facing the resistance? What is the meaning of resistance? Diagnostic dilemma, and what is happening to special population. So when you talk about this, see this problem of recalcitrant cutaneous mycosis has not remained in our country, but it has become the problem of all South Asian countries. And this problem, all of us we know, is because of indiscriminate use of steroids, antifungal treatment by general practitioners, by the chemists and OTC products. Everything is aggravating this or compounding this. So this has become the problems in South Asian countries. Of course, then a lot of research is going on. And now what they found is T. mentagrophyte type 8 mutate strain. And now they feel that 2 rubrum, which was very common, is shifting to T mentagrophyte. One of the studies shows 93% they found T mentagrophyte. This T mentagrophyte, which was initially is a zoophilic, but now it's become anthropophilic. Like I think it is happening with the many other infections. Like the HIV is also the same thing. It was a chimpanzee or the green monkey. It's come to human being. COVID, there are many infections which are present in the animals. Now they are coming in the human being. Probably overall our immunity is going down. That's why I personally feel. So I also conduct a lot of webinar on mainly on the antifungal. And then this is the question first I ask. So most of the people, they say almost 10 to 30% the patient attend their clinics having tinea. So tinea is there is an exponential rise. So why this rise is there? There are many studies, there are many reasons, but they say probably because of overcrowding, lifestyle, diabetes, which is very common, almost 1% is every 6 person in our country is suffering from diabetes, socioeconomic conditions, of course, the high humidity, tropical conditions. These are the many reasons they have given. Apart from, they say the treatment with the steroid. Steroid is the main things according to most of us. Inadequate treatment, irrational combination, drug resistance, and ping pong effect. There are many reasons, but these are the few reasons we know it. So when there is an exponential rise, so it's not only increase in number, but there is changing in the clinical pictures. Like we find a recurrence, relapse infection with a higher frequency, extensive lesions. Like this, they get extensive lesions, unusual, atypical, aggressive, number of lesions, morphology, everything is changing in this today's pictures of the tinea. I remember as a HIV clinician, we used to say any common disease present with unusual, atypical, aggressive presentation, think the patient is immunocompromised. And it is true. So the patient is coming with the extensive tinea, he is also immunocompromised. The reason may be different. It may be because of HIV, it may be diabetes, because of applying a steroid, but the patient is immunocompromised. That's why they are getting this extensive recurrent this thing. Previously used to call mainly because of HIV, but yeah. Another presentation, if you look here, if this patient comes to any dermatologist, even I would have thought of Chapel dermatitis, but it turned out to be tinea because the application of steroid. So chronic nature of the infection, it has not remained acute. Intractable itching, itching is so severe that even this itching persists, even the clinical resolutions occur. That we never used to see before. Rapid shedding the close contacts, like we are seeing 3 to 4 family members are affected. Previously hardly used to see. It is affecting children. That was not the pictures in those old days. And persistent pigmentation when the lesions. So these are the various presentation all of us we are seeing. These are the picture. See such a extensive, this lady, I remember she was taking antifungal treatment for 2 years before she came to my clinic. See, this looks like a eczematization, the lesions on the face, concentric layers, lesion on the leg. See, if you look at this map, almost it looks like a map of India, this design, so all various design, extensive lesion, concentric layer, and the complicated steroids, because the OTC product easily available. And that day I was discussing, they said fixed drug combination, the steroids and fungal combination, steroid and antifungal combination is responsible, because that is the natural. Anybody gets anything in the skin, they go to OTC, they buy steroid, apply, they feel better, so they are happy initially. Then I was talking about the mycologists. They said, sir, they will not change only in the clinically, but we are started finding the zoophilic, which was not seen before. Now we have started zoophilic, that is mentagrophytes. I'll give the example in a Microsporum canis. This they have started seeing in Tinea corporis, Tinea cruris, or Tinea on the other part. Then the abundantly, a massive build-up dermatophytic. Previously, they used to find very difficult, but you can demonstrate very easily with the KOH preparation. So when these things are happening, what are the challenges of dermatologists? We call it a catch-20 situation, delayed response to treatment, either partial response or no treatment is a big problem in clinic. Large number of family members are affected. So the cost becomes the problem, because all members can't afford it. Lifestyle, then lack of adherence compliance, because most of our clinicians, they are so much flooded with the patients, they do not have time for the counseling, chronic nature of the infection, lack of the counseling, side effects, drug interaction. Many patients now, I think many of us, we are living more than 65 years with comorbidity. So already there is a pill burden, so there is a lot of drug interaction. Many people, many our dermatologists are using combination of multiple antifungal treatment, then suboptimal doses, higher doses, longer duration, and of course indiscriminate use of steroids like cordridum, pandem, which is easily available to the patient. So these are the various problems we are facing. So we started working about 4 years back. Why this is happening? This is happening because change in the epidemiology or change in the species. So we started working on it. This is one of the quite early one of the data from the Chennai, where they say T mentagrophyte is the T rubrum is common. T mentagrophyte is still not common, but but as days are passing, you'll find on the various part of India, you'll find the T mentagrophyte is on the rise. If you look here, north of India, T mentagrophyte is on the rise, while in Tamil Nadu, Kerala, and Maharashtra, there is a T rubrum is still common, but percentage-wise, T mentagrophyte is on the rise. So these are the studies. This is one of the studies where you say T mentagrophyte is almost 92%, and rubrum is only 11%. Of course, this study is from all over the country. This is another study from northeast. Is from the Kolkata. Sudeep Das and Abhishek. What they say, they found Trichopanto verrucosum, which is actually zoophilic. It has become is one of the common. They found 53%. Of course, trichophyton is 89%, but T rubrum is only 30%. So there is a various, we need a lot of research, a lot of studies, but if you go all over the world globally, still T rubrum is a common in Western world. So we started working with the various mycologists, Dr. Miskin from Mumbai, Dr. Madhu from Chennai, and Dr. Anupama from Hyderabad, and see what we found. And then what we are thinking of Trichopatum robishanki with what we call is the molecular biology, that in sequencing found Trichopatum robishanki is not a new species, is a subspecies of Trichopatum rubrum. Similarly, Trichopatum interdigitalis is not a new species, is a Trichophytum subspecies. So what we require is a sequencing or a molecular biology. So there are hardly any new species. There are subspecies of the what are the existing isolates are there. So now talking, then everybody, I remember 4 years before, everybody was talking and resistance and resistance. Everybody is to come, MR is to come. Sir, there are a lot of resistance. Any national meeting, resistance. So we started working on the resistance. I said before talking about resistance, let's see what is happening. So this is one of the study from Sheetal Pujari from Mumbai with Miskin. They found there are downy form and the granular form. And granular form where usually the response is slow compared to downy. That was the reason. This is another study where they found there is resistance to terbinafine. In Uttar Pradesh, 18% they are resistant to terbinafine. If the concentration is, what concentration of terbinafine is required is more than 1 microgram. In Chandigarh, it was required more than 2 microgram. In Delhi, 4 microgram. But they were not resistant. They say there was 76% resistance. So actually, that was not resistant. It was, they were not responding to the treatment. If you see another study from Abhishek Dey from Calcutta, if you see the sensitivity test, the grizofulvin has got 60% to verrucazum, 65% to ribram, and mentagropyl 58 compared to terbinafine. So, you know, these are the various studies. We have to gather these studies. But this is the another study from Ananta Kurana from Delhi. What they said, we require the help of molecular biology and sequencing to find out what is happening in this world. This is another study again. They say metagrophytes, sorry, terbinafine for till metagraphite 72% and T rubrum is 39% resistance. But this is in vitro. This is not real. Yeah. This is another study from Japanese. They said only the 2 patients they found a T rubrum which are resistant to terbinafine. Only 2 patients. This is Pietro. He has done a lot of study and their group where they found what is called T metagraphite and T interdigitalis trichophorin involving the tinea cruris, tinea corporis, and other part of the body which was not known. So these are the studies. And this is the another study from China. What they said, our study in that terbinafine was still the most active drugs and they did not find any resistant to teibribram or resistant to terbinafine. So their first line of therapy is terbinafine. So the various geographical area, there are different species, there are different sensitivity. This is the study from, again, Pietro from Germany, where he say the molecular diagnosis is necessary if you are suspecting the resistance. They have found what is called trichomentagraphite ITS genotype 8, which is resistant to terbinafine, but they respond to itraconazole and other. This is one of the picture he has shared that if this patient would have come to my clinic, I would have thought probably the patient has got opportunity infect due to HIV, underlying HIV. I would have thought that. But this is again tinea trichophyton, and they say trichophyton now is included in a sexually transmitted disease where T metagraphite they have found in 7 patients like this. So clinical picture is changing. And but here they said it was the patient responded because it was trichophyton genotype 7, not genotype 8. And these are his studies only. When there is a genotype 8, usually resistant to terbinafine is 53%. But if it is genotype 8, not other thing. So these are the various information that studies we have. So then we started studying and find out, are we really dealing with the register or it is something else? So we started doing this. And then first I said we should know what is the definition of resistance. For example, once you say the resistance, you increase any concentration of the drug, the organisms are not going to respond, that is resistance. While if your diagnosis is correct, your treatment is appropriate, but the patient is not showing any clinical response or partial clinical response, that is a clinical failure. And this term was given by us in 93, 94. We used to get esophageal candidiasis in HIV, we used to give fluconazole, patients were not responding. But when their resistance power, the CD4 count used to come up, with the same fluconazole, they were responding. So that is called clinical failure. So we used to call unresponsive esophageal candidiasis. But by 2000, the American clinician, they gave one the name clinical failure. So now they call clinical failure. So going again, now talking about there are the various stages where the antifungal works like alenemine, there's squalene oxidase, that is ERG1, azole on the C14 alpha demethylase, that is ERG11, amorphylline at 2, that is reductase and isomerase, that is ERG24 and ERG2. And of course, Paulins is an orgastol. These are the various places. So when you talk about the resistance, for example, resistance to azole, there has to be mutation at ERG11. If there is no mutation, you cannot call is the resistance. For resistance, you have to show that there is a mutation. If there is no mutation, you cannot call it a resistance. So why there is a mutation? There are many methods of mutation. In echinocandin, paradoxal effect, they said is the filamentous fungi, they are responsible. In a pyramid, what is like 5-fluorouracil pyramid, where biosynthesis is very important, the ergostal and the biofilm. These are the various reasons they have given, but still work is required. Then talking about the drug, talking of the grisophulvin, if you see T rubrum, the grisophulvin concentration has gone up 0.5. T rubrum again, fluconazole, it has gone to 1. The concentration again for the terbinafine, it has gone to 0.01. Fluconazole, say itraconazole 0.6. So the concentration of the drug is required, more concentration is required than, but the treatment is effective when you increase the concentration. That means it's not resistant, it's a clinical failure. For example, I remember when the dot therapy came for TB, I was deadly against it. I said, this dot therapy you are giving alternate day will cause, or this is the mother of MDR TB. And now we see a lot of MDR TB because the dot therapy you are giving suboptimal doses. So what they say, the concentration is very important, and the concentration in the corneum, stratum corneum, if the stratum corneum concentration is less, serum is high, it's not going to work. So this is one of the study of Kabir Sardana from Delhi. What he said, we are not dealing with the resistance, we are dealing with the clinical failure more than the resistance. Yeah, so then we went back to our original, what we learned in the second MBBS. The response to any infection depends upon the virulence of the organism we saw, except that T mentagrophyte genotype 8, all organisms are same. Then organism are same. Then the second point is the chemotherapy. Here we have got very potent drug like itraconazole, fluconazole, terbinafine. When we have got a potent drug, then what is problem? So I feel the problem is the host immunity. Over the years, our human being, the immunity is going down, and that's why what are the diseases they affect the low immunity like the animals. Animals have got low immunity compared to us. So those are transmitted from animal to human being. So main cause is the host immunity, and tinea application of steroid, our immunity goes down. And of course, environmental. So this is the questions I asked in the audience since COVID time. I conducted total 37 webinar on antifungal. The first question I asked, any patient comes to your clinic, what is the percent of the patient that responds to you start any antifungal? Griseofulvin, terbinafine. So Lalit, you are there. Can you answer this question? Lalit? Okay. Dr. Agarwal? Okay. If they're not there, what we find, they said more than 70.
They are there, but we will open the.
Okay, but Dinesh, you can answer this question because the poll opinion more than 75%, almost 80 to 85%, you start with antifungal, they start responding initially. Do you agree with that, Dinesh?
Yes, yes.
Yeah. So when they start responding, that means it's not resistance, it's a clinical failure. So this is the first thing we realized about 3.5 years before.
I also don't agree with the term of resistance in the sense what you spoke earlier, 18% or 15%, probably that is not the reality. That 18%
Yes, yes, correct. Yeah, yeah. So anything you want to add in the Dinesh?
Oh, no, no, thank you. It's a very
Okay.
interesting
So we then I said we are dealing with the clinical failure, and then we started looking for what are the causes of clinical failure. So there are causes from the patient, from the pharmaceuticals, and we doctors. And in our doctor is lack of counseling. That's we realized. Then he said, why there is a clinical failure? Then we started looking for the literature. And in the literature, we found that American literature, now the tinea has not remained the acute infection, but it has become the chronic infection where the immunity is produced by the acute infection, that is antibody is not enough. So what he need is a cellular immunity. So now when there is a defective cellular immunity, the patient led them into chronic infections, and we are dealing with the chronic infection because it's taken over by the cellular immunity. That is first thing. Secondly, the patient, they were coming 6 months, 1 year, 2 years. So now I'm happy that IAD, there are articles, published articles, that duration of the treatment should be long. This is one of the international paper. They said sometimes the duration can be 3 to 6 months. So the chronicity or the relapse and recurrence is number one, because of chronic infection. Secondly, long duration treatment. And thirdly, because of the adherence. So we started working. That time they said, give terbinafine 2 weeks, give the gap of 2 weeks, another 2 weeks. Fluconazole, give once in a week. That interruption therapy is not going to work at all. Any chronic infection, whether it's a diabetes, whether it's a malignancy, HIV, it has to be continuous therapy. So this is another thing we realize in dermatophytosis. What we are doing is a recalcitrant. We require is a continuous therapy, no interruption therapy. So then we started working on this, and when we started working on this, 1 second, why this is not in anyway. We started working on it. We did a study. We studied about 100 patients by giving itraconazole, 100 milligram BID, no 200, no 400, with ibuprofen local, and we found 82% of patients showed complete regression. There was no recurrence and no relapse followed for 1 year. 18% there was a partial response. Out of 16, their adherence or compliance was not good. 2 patients were on steroids and methotrexate because rheumatoid arthritis. In the repeated counseling, 16%, some of them improved, and none of the patients did not show in initial response. So there was no question of doing any culture. So this result, we could get it because of counseling, nothing else, only counseling, and treatment was continued minimum 6 weeks, sometimes in few cases 3 months. All family members were treated at the same time. Clothes were washed in the hot water and iron. These are the simple counseling has helped us. So then we look for the international literature, and according to international literature, there are many causes, but the important cause is the poor adherence to the treatment is the cause of recurrence and the relapse. And even this is one of the study in HIV where patients were not respond to antiretroviral therapy and they were recalcitrant, where the same antiretroviral therapy was given by the doctor, what we call is the dot therapy, and patients started responding. Even the HIV is so dynamic, with the improved adherence, the patient started responding, their virus load came under control. So adherence and the compliance, we realize, is an important cause, and that's how we started working. In my clinic, any patients of tinea comes, we have got a special doctor in the separate special room. The doctor will talk about the counseling, adherence, and compliance 15 to 20 minutes. Each and every patient of tinea, we give 15 to 20 minutes, and we are getting wonderful results. So these are the various reasons of relapse, recurrence, that is the immune state, ping pong, drug-drug interaction, many causes are there. But one of the important is a poor adherence to the treatment. These are the result of cases. These are the patient came to our clinic. These are the results. Very good results. So now the question comes, next questions come, because many clinicians, they write, for example, a friend of mine is writing terbinafine, fluconazole, griseofulvin, 3 tablets together. So is it? Then we thought we had taken the second issue, whether they require multiple drugs, multiple systemic drugs or not. And we started working, and you must have realized we have used only itraconazole in that. When itraconazole started working, they said, let's try terbinafine. With a good compliance, we got a good result with terbinafine. Then we started fluconazole, but fluconazole daily doses, and you got a similar result. So what is lacking according to us, this is our finding, that adherence and the compliance plays the major role, and duration 6 to 8 weeks minimum. So whether we should give the combination multiple drugs, this is another friend of mine is writing. So there is a consensus group, they said you make itraconazole 200 BID, give longer time. They started working, then we realized the patient, if we give many drugs, there will be pill burden, more toxicity, more drug-drug interaction. The cost will be like a sky high. The patient can't afford, and the compliance will get hampered. So we started working, and we realized single drug is enough. We do not need more than one drug. And you can use itraconazole, you can use fluconazole, or you can use terbinafine. We do not have experience about the griseofulvin. Probably we are not using it. Yeah. So role of now updosing, that was a combination updosing. When you talk about updosing, the consensus group of they say you increase to 400 milligram and all these, but I wait for international literature and our clinical experience. International literature, Journal of American Academy, they say evidence is lacking in updosing. And in my clinic last 3.5 years, we give only single drug. We never given 2 drugs. We have never raised the doses, except the weight is more than 75 kg. We give itraconazole 200 milligram BID initially for 20 days. Then coming to children and mother, when mother are getting, now the children are getting infected. This is the 9-year-old boy is coming. So when the children comes to your clinic, I think itraconazole is not the drug of choice. Either can use fluconazole or you can use terbinafine. These are the 2 drugs you can use it. And this is the result with the fluconazole. You use the fluconazole and you got beautiful result. This is the international studies where they say safety and tolerance of fluconazole in the children is far, far better than adults. So fluconazole is very safe drugs and can be used. Only thing when you are using fluconazole in neonates, the dose should be at the interval. You can use first 2 weeks. In the interval, it should be 72. After 2 weeks, first 4 weeks, it should be 48. Fluconazole should not be daily. It should be every 3rd day, first 2 weeks, then every 2nd day, up to first 4 weeks, and then the routine. Yeah. So pregnancy, these are other things. In pregnancy, it's very clear terbinafine is a drug of choice. If you are using fluconazole, you can give only single drug in candidal vulvovaginitis, not for the tinea. Other drugs are not advisable at all. Then coming to many people are writing caspofungin, posaconazole, oriconazole, they're writing. Fortunately, I'm attached to the All India Institute of Diabetes, where there are about 100 oncologists are working. So they are using all these drugs, but that is for systemic, not for this. So many people are using oriconazole. So I thought I'll touch this. So these drugs, oriconazole, itraconazole, they are useful only for systemic. There is no study where you can see that these drugs are useful for tinea, number one. Number two, one of the dermatologists working as a mycology in Indonesia, she was speaker in Dermacon 202 at Pune. She made it very clear, voriconazole concentration in serum is very high, but stratum corneum is very low. Number two is side effects are more. Number three, it requires therapeutic monitoring. And number five is very expensive and it is never used for tinea according to any literature. So I do not know why people are using oriconazole for tinea or dermatophytosis. Systemic, definitely you can use it. Then the another problem what you see is in immunocompromised patients like getting tinea like cancer, diabetics, elderly or the children. The immunocompromised patient when they come, their presentation is atypical. I'll show you. Their presentation is atypical. For example, if you see this patient is a diabetes, see you won't get any active border at the periphery. You get the diffuse. So this is the tinea in diabetes. This is a tinea another in diabetes. This is the tinea in my HIV patient. No border. You cannot define border, but you can suspect. This is again the same thing tinea in diabetes patient. So these are so where when you can suspect clinically, we need help of KOH preparation, and KOH can demonstrate this mycelia very easily. Fortunately, in my both the clinic, I have got the microscope, and we are doing KOH. The day I started my clinic, that is 42 years back, KOH is routinely done when we suspect. Of course, now we have got culture sensitivity, we have got PCR, we have got many things and can be used in the future. So this fungal infection immunocompromised patient, there is the atypical, like in children in atopic. Many times we are perplexed whether it's atopic or this. That is a time we have to take help of mycology if you are not good. But I can tell you, all dermatologists can learn within half an hour how to look for the mycelium and the spore. It will take half an hour. Yeah. So next question is, now we have seen many members of the low social group, they are affected by tinea. So when they are affected by tinea, we started working. Terbinafine, itraconazole are effective, but they were expensive. So we started working about 3 years back. And with the background of the HIV, I started using fluconazole. Only thing I looked for the pharmacodynamic and I found fluconazole concentration goes up within 3 to 4 hours, very high. But last only 24 to 30 hours. After that, it declined. And the MIC of fluconazole is high. You have to use fluconazole daily, otherwise it's not going to be effective. Because many friends of one of the sensitivity test I showed that Dr. Abhishek they has done, they say this fluconazole sensitivity is very low, but they are used once in a week. You have to use daily. Then only can maintain the MIC of fluconazole. Because it's a very cheap drug. HIV has taught us, start working for the masses. We started working for the masses. I said each and every patient should afford, they can't afford to go to government, but they should be afford to take the treatment. And that's how we started working with the fluconazole. And we are very happy last 3.5 years. My main treatment is fluconazole 150 ml daily 6 to 8 weeks. This is the patient, if you see, he has gone cardiac bypass, is diabetic, hypertensive, and he has got psychological problem. Now he has come with a severe tinea. So he has got a multiple problem, what is called, he is a polypharmacy. So which drug you will use in this patient? See, this patient came, this is the history we write. This is how the case patient of CABG, hypertension, diabetes, He is on Lasix, he is on Cetapine, he is on digital, many drugs. And our diagnosis extensive tinea. We started tablet fluconazole and patient responded very well. Because many clinicians, they feel itraconazole metabolism is CY3A4 and which is the what is called enzyme inducer. So when this CYP34 is there, that cause the liver increase the liver metabolism and drugs is excreted fast. So they thought, and there is the effect on the liver. So they thought fluconazole is also same group. But if you see fluconazole, this is that was itraconazole where it affects the liver because CYP3A4. Terbinaffine's metabolism is CYP2D, which is very good drugs, hardly any drug-drug interaction except antipsychotic drug, fluoxetine, paroxetine. So this patient has psychological problems, so we could not use it. And so we used it. Fluconazole patient is doing very well. So says fluconazole metabolism is CYP2C19, not 2CD like terbinafine. So it has got hardly any drug-drug interaction. One of the things said fluconazole like itraconazole can cause QTC, prolongation of QTC interval. But this is one of the studies done. What this study said, our study that fluconazole dose of 1200 milligram do not lead to clinical significant lengthening of the QTC interval, prolonging of the QTC interval, and no QT interval ECG monitoring is required if the doses are very small. We are using only 150 because many clinicians feel it is there. This is another study, rifampicin, warfarin, hypoleucine, phenytoin. You cannot combine with itraconazole, but it is safe with the fluconazole. So fluconazole is very safe drug. There is hardly any drug-drug interaction. Like this, where you can use, you cannot use itraconazole. There are a lot of side effects of itraconazole. Sorry, drug-drug interaction. So of course, now the patient of course, oh, sorry. So this is a drug-drug with the rifampicin. You cannot use itraconazole with isoniazid, but you can use fluconazole and terbinafine both. Patient with a diabetic patient comes, which drug will you use? Of course, terbinafine is a drug of choice and fluconazole also is a drug of choice. Both you can use it. So then we know there are so many systemic drugs. So which is the ideal drug? We started working, which is the better drug. To call ideal drug, what we require is a potent drug, effective drug, safe drug. It should be used for long term and have complementary additive effect with the other drugs. Minimal drug-drug interaction, cost effective, quality of drug should be good. There are many characters. So which drug can, yeah. So which systemic antifungal can, yeah, is terbinafine, fluconazole, grizovolin. We started working and I found fluconazole is one of the best drugs as per all characteristics. That is the efficiency, potency wise, safety wise, the cost wise, and prolonged period treatment wise. So if you look here, the bioavailability of fluconazole is 90%, while itraconazole is only 55%, terbinafine is 72. Metabolism, there is a minimal metabolism in fluconazole. Tissue penetration, fluconazole can penetrate any tissue, whether it's a lung tissue, whether the spleen, the brain, anywhere. That's why cryptococcal meningitis we use fluconazole. Mycological safety, that cure is 83% the fluconazole compared to itraconazole on this. So if you take a resistance profile, fluconazole is better. I'll show this one of the study of Dr. Kabir Sardana, where he said terbinafine, itraconazole fail, fluconazole work. So fluconazole is one of the very good drugs. Then coming to concentration in stratum corneum is 40 times more than itraconazole and terbinafine. So this is wonderful drugs. Only thing, this drug has not been used, is not given the book, but with the HIV background and working for the poor people, I started using this. Even if you see the penetration of fluconazole can penetrate any tissue. It can go to sweat gland, it can go to dermis, epidermis, internal, and the deeper tissue. Now, when you apply you apply this any steroid, the tinea or dermatophytes, they go in the deeper tissue. I'll show that study. So according to me, I'm now doing one of the studies, the fluconazole 150 milligram daily, where I'm showing one of the patient. This is the first patient came to my clinic, first time, first visit. This is we do KOH. You can see a lot of mycelium and spores. This is second visit where the erythema or the redness has disappeared after 2 weeks. This after 4 weeks, no activity. And after 8 weeks, no activity at all, everything is cleared. And if you see KOH, no mycelium. So this is how we are trying. I have completed 50 patients, and I would like to tell there's only out of 50 patients, 47 patients. Now, of course, we completed 35 patients, completed 8 weeks. There is a complete resolution, and only 3 patients showed recurrence within 2 weeks. I was surprised. I said, my own practice, I'm not seeing recurrence. How come in a clinical? But then by asking questions, you'll be surprised. All 3 family members, in spite of telling them, bring your other family member, treat them, they were sharing whatever the fluconazole we gave from our clinic, they were sharing. लड़के को थोड़ा देता था, daughter in law को देता था, खुद को. See, so sharing this we have seen with the HIV. Dinesh, you know that HIV patient used to share their medicine because of stigma. They never used to bring their wife. But here, because multiple patients are affected, they were sharing. That's why. And now we are very careful. We do counseling. If you want, you bring your. We don't charge for this, but still, this is the phenomena we came across. So according to my experience, fluconazole is a very good drug because absorption 90%, protein binding, no general restriction. You can take before food, after food, no hepatic impairment, cardiovascular, minimal drug interaction, safety profile, high concentration, high potency, 86%. So the take-home message, tinea corpus cruris is completely treatable. And all drugs, whether fluconazole, terbinafine, itraconazole, they are effective, and single drug is required, no need of combination. Fluconazole should be given daily, not once in a week, twice in a week. Terbinafine should be 200 milligram BID, not 500 milligram OD or 250. Because high concentration is required. And it should be longer duration. Minimum duration is 6 weeks. It can be 3 months in some cases. Adherence and compliance plays the major role, and counseling is the utmost important for the treatment of tinea. And what we are dealing is in the what we call is a clinical failure rather than the resistance. So my request is, we are dealing with the clinical failure. Please use whatever the existing drug in proper doses and proper duration, so you won't see any resistance or will be able to treat this patient. So lastly, I would like to say the compliance, adherence, judicious prescription, and preserve the existing drug. Don't give what we call interruption therapy, and give time to counseling. Don't say resistant patients are not responding. I think I should stop here, and thank you. Thank you very much, Dinesh, Lalit, and Dr. Agarwal and your team for giving me this opportunity.
Thank you very much.
Yeah.
Thanks a lot. And Dr. Lalit, can you please take up any questions or comments? And then the first of all, the main question by Dr. Niranjan Nagpur, sir.
Yeah, no problem. Yeah, I can stop sharing. Okay, yeah.
Yes,
Yeah, that I think where I have to go, stop sharing. Yes.
I'll do it. I'll do it.
Yeah. Okay. Yeah, no problem. Yeah.
Supply,
Yes.
supply.
Yeah.
You see, what I want to find out is that about 10 to 15 years back,
Yes.
the fluconazole was mainly meant for candidal infection, which was not working for a dermatophytosis.
Yes.
Now, why it is working?
Yeah, that's why I think if you listen to my talk, I made it very clearly. And I entirely agree with you. Fluconazole, the concentration required for candida is very low.
No.
It works once in a week or twice in a week. But in dermatophytosis, the MIC required is very high. And fluconazole can maintain MIC only 24 hours to 30 hours. So you have to repeat fluconazole with it. So previously they used to give once in a week, but you give daily, it works. Is it okay, Dr. Nagpur?
But anyway, now I'm following your method of treatment of giving fluconazole.
Yeah.
Why still among all the dermatologists in India, if you look at it, but still everybody prefers itraconazole?
No, see, what anybody is right is there, but if you want to write for the poor people,
Yeah, that I agree with you.
yeah, and when it is effective, I'm doing this study with the ICMR, fluconazole 150 milligrams. I've taken the highest permission of the country because we want to do it properly. Because I'm sure myself, another question they ask, to giving fluconazole 150 daily for 6 to 8 weeks, there is no problem. It is very safe. In HIV, we used to give 1200 milligram IV for 21 days and maintain on 400 milligram 9 months to 1 year. So it is very safe drug. Last 3.5 years, I have not come across any hepatitis, any renal problem, or any suppression of CBC.
That's good.
So, Dr. Saple,
Yeah, Lalit. Yeah.
it was an excellent talk as usual, as always. I have two, three queries to clear.
Yes.
One is that if you look at the pharmacokinetic profile of fluconazole,
Yes.
it is a drug with a fairly long half-life.
Hmm.
So it's around 24 to 36 hours.
24 hours to 30 hours. Yes.
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 And it also has a good reservoir effect in the stratum corneum. So if you can give a loading dose for about a week or two,
Mhm.
and then follow it up with maybe twice a week or thrice a week, what would be your take on that? Because anyway, the drug is there in the
Yeah,
stratum corneum.
yeah, Lalit, that's why I entirely agree. What I have done is not the last answer. As you said, I entirely agree with you. We have to try instead of 150, we can try with 100, we can try with 50. Not necessarily 150 is required. 150 may be enough. And as you say, alternate day we can maintain, can be, but we need a study or somebody has to have. I entirely
Exactly.
agree with you. That's
So that,
why I'm talking to all pharmaceuticals. Why don't you try? You try with the other doctors, at least giving alternate day. Instead of 150, give 100. Give minimum. We do not know what is the optimal doses. I entirely agree with you, Lalit.
the other question is, sir,
Yes.
that itaconazole and greasevolvin tend to be excreted through the sweat,
Yes, correct.
and it has got a very minimal levels in the sebum.
Yeah.
So do you see the patient or select the patient based on their sweating profile? For example, in axilla or maybe in the groin area or the hairy areas, the fluconazole is likely to work better compared to the oily areas. Is it based on the secretion profile of the drug,
Yes.
the
That's why,
selection of the patients,
yeah, that's why I
selection of
showed
the
one
patient?
of the slide. Fluconazole penetrates each and every tissue of our body. What is happening with the other, like itraconazole, grisoformin, terbinafine, they have got limitation. But fluconazole penetrate each and every tissue. So whether in the sweat area, is a sebum area, fluconazole works. Yeah, very good
That's
question.
apply
Yeah.
that
Do you
if there is
do you
senior
yes, sir.
capitis, senior capitis. So
Dr. Nagpur, Dr. Lalit wants to another question, then I'll come back to you. Yeah.
The other thing is, sir, do you base the dosing schedule based on the body weight of the patient, or is it blanket 150 milligrams?
No, the dose is 3 to 5 milligram per kg body weight in children. But children always, the doses are the higher. So if you take 3, and on average, Indian is 60. 16 into 3. So I calculated that uh, uh, from the children because the dose should be on the lower side in adult. So that I have taken 150. Yeah.
Thank you, sir.
Yeah.
that's apply.
Dr. Nagpur, yeah.
Yeah, you see, what about your experience in senior capitis? You still feel gluconazole is the drug of choice, or because many people say that terbinafine is the drug of choice?
See, Dr. Nagpur, according to literature, drug of choice for tinea caput is the grisofulvin. But of course, I hardly see any. Yeah, let me finish. Grisofulvin is the drug of choice for tinea capitis. But Dr. Aditya Gupta, who has done maximum work, he said that shorten the period. He has used fluconazole, he has used terbinafine, he has used itraconazole, and he say by giving this drug, we can shorten the period of grisofulvin requires for a longer period. So he said 4 weeks should be enough. That one of his studies there where he has shown fluconazole, terbinafine, itraconazole, all are effective. In fact, their period is short. That's what his study says. But I do not have experience of tinea capitis. Yeah.
Dr. Rajesh Rajgopalan wants to share
Yeah.
that fluconazole can cause urticaria and angioedema. He says he has got 1% with the side effect. So I think that can always happen with any drugs. So
Uh, yeah, I think this is a good. Anybody sharing is always good because we learn from each other. I have not seen any side effect, but one of the patient I have seen fixed drug reaction
yes,
with the fluconazole. But that's why we have to start sharing.
true.
Yeah, the speaker doesn't mean he knows everything. We have to learn from everybody.
So
Yeah, good thing Dr.
just
Rajgopalan is very good. Yeah.
in that note only, sir, I just wanted to share with you and concur with you
Yeah.
that we have reported 2 cases of fluconazole induced FD. One is pigmented normal FD, routine FD. The other is non-pigmented FD.
Oh,
So we have also reported non-pigmentary fixed drug eruption to fluconazole.
okay. Thank you.
Dr. Rajesh Rajgopalan again says that up to 8 milligram per kg body weight has been tried in nail infections. So I think higher doses can be tried.
Yes, correct. I was just talking with the dermatophytosis and diabetologist. But in the diabetologist, they come across onychomycosis is very common in the diabetes patient. And I was just going through the studies, and the international literature says fluconazole is the best drug compared to itraconazole, terbinafine, and grisofulvin. That is the article says. But if you ask me, onychomycosis is a very difficult to treat. Whatever you do, that is my. I think all of us will agree. No, onychomycosis is very.
Yeah.
Yes.
The other thing, supply, have you come across any time itraconazole inducing the edema of the hands and feet? Because some people were saying that they find this swelling of the hands and feet with itraconazole.
Yeah, no, itraconazole is known for edema of the feet. You know why edema of the feet occur? That's why I showed one of the slides. When you use itraconazole causes slowing of the myocardium conduction. When the myocardial conduction goes down, there is a possibility of cardiac failure. That's the reason they do. But that's why I showed in fluconazole. One of the study, they have given 1200 milligram of fluconazole daily, and they have monitored and they found QTC interval doesn't prolong. So fluconazole is safe, and in last 3.5 years, I have not come across. But if anybody come across, please share with us. But they're less likely because it's not affecting the QTC interval. Yeah.
Because one of my classmates, he had a fungal infection.
Yeah.
He took itraconazole, and then he started developing.
Edema of the feet with the itraconazole is well known. Yeah, it will happen with itraconazole. That's why I mentioned many people feel it is happening with the itraconazole. It should happen with fluconazole because azole, but it is not so.
Because they call it the capillary leak syndrome.
Yeah.
So sometimes it can be a fatal.
Yeah, because myocardial, no, the cardiac fails means it will be fatal. You cannot continue. Even a hypertensive patient, you have to monitor if you are given itraconazole. That's why I come with a very simple solution, fluconazole. Anyway.
So he is a fluconazole man.
I know, that's what